This is a presentation on chronic kidney disease. This is aimed at nursing students.
Morning. Morning, how are we?
Good, how are you?
Yeah, not too bad, thank you. Okay, I'll quickly just brief you over this patient that I had last night. Her name's Miss Allen. She's 65 years old. She's got a long history of hypertension and has recently developed type 2 diabetes. She's not on any medication or anything for that at the moment, as it's fairly new. And she's also a pack-a-day smoker. Miss Allen complained last night of pruritus and swelling of the ankles. She also complained of nausea, restlessness, muscle cramps. She didn't have a very good sleep. She also vomited 100 ml of sputum last night. Her blood pressure is 170/100. Her heart rate is 80.
When's the last time we've done her blood pressure?
So an hour ago. So we're going to try and keep it on an hourly basis as well, 1 to 2 hours. And her respirations were slightly elevated at 24. Her lab results came back from her blood and urine tests. She's got elevated potassium levels at 6.5 millimoles, and her kerosene levels are at 16 milligrams. She's also got albumin in her urine. And her red blood cell count came back at 10 grams per 100 mils. She also had a low pH and a GFR of 8.
Okay.
Yeah, so pretty much, obviously, she's in the the late stages actually. Chronic kidney disease, sorry. So pretty much all we're going to have to do is keep her comfortable, keep her stable. She will be starting dialysis. I'm not sure when the doctor is going to put her on that, but for now we just have to keep her on her regular medications, keep monitoring for whether she's getting better or not, for the doses, because the doctor needs to be altering them if they're not working. So if you can just keep an eye on that, and yeah, just keep her comfortable for now. Other than that, have fun.
The role of the doctor is to educate the patient about the condition and also to gain consent for the procedure. Good morning, Mrs. Allen. Just sit up the bed.
Stop.
How are you feeling this morning, Mrs. Allen?
I'm okay, thanks.
That's good. Now, so I'm here to talk to you about your condition and also gain consent for the procedure, okay?
Okay, yeah,
So first I'll talk to you about your condition.
Yep.
So as you're aware, your kidneys have not been working properly,
Okay.
and with examination, it shows that you are in stage renal failure, which is stage 5.
Is that bad?
This is bad. It is a very serious condition, as it can build up the toxins and fluids in kidneys and to the rest of your body.
Is that why I've got a demon?
That's possibly why you have a demon, yes.
Okay, yeah.
Right, so unfortunately, as I said, your kidneys are no longer filtering by themselves.
Okay.
This is why the toxins are building up.
Can I just ask, is it reversible? Like,
No,
can I?
it is not reversible, I'm sorry.
Okay.
So what our treatments that we can offer is dialysis, and I'm also here to gain consent to put you on a waiting list for kidney transplants.
Okay.
We will need to take some tests to see who you're compatible with as well
Okay.
for your kidney.
Okay, no worries.
But that can take a while, so that's why we need to put you on dialysis first,
Yep.
unfortunately. But
Okay.
this will just take over your kidney's function.
Okay. So,
Alright,
yeah.
so I'm going to leave you in the hands of Catherine, and
Okay.
she's going to go over the consent form with you.
Okay, no worries.
After speaking with Miss Allen and the doctor, my next nursing intervention is going to be to assess Miss Allen's vital signs, as this is an hourly requirement, and it's going to give me an indication as to whether or not she's deteriorating. Miss Allen, is it okay if I do your vital signs?
Yep, it's fine.
After performing Mrs. Allen's vital signs, it's important to document the result.
Chronic kidney disease is the gradual loss of kidney function over long periods of time. The disease includes conditions that damage the kidneys and can decrease the ability of normal kidney function. CKD can cause the bypass of waste products to build up in the system and in the blood, and as a result, it can cause numerous complications on the body. These can be in the form of high blood pressure, anemia, nerve damage, and it also increases the risk of heart and blood vessel disease. People more at risk of developing CKD can be people who have diabetes, high blood pressure, have heart problems, or have had a stroke, who are smokers, obese, and have a family history of CKD. As there is no cure for CKD when diagnosed, often early detection and treatment can reduce the impact of CKD on the body and prevent the disease becoming worse. The treatment of CKD can include dialysis or even a kidney transplant to maintain life. High blood pressure, also known as hypertension. Hypertension over time can damage the blood vessels throughout the body. Hypertension can damage the cells of your arteries' inner lining, as when fats from your diet enter your bloodstream, they can collect in the damaged arteries. Eventually, the artery walls become less elastic, limiting blood flow throughout the body. Due to these damaged blood vessels, it reduces the supply of blood to the important organs like the kidneys. As a result of damaged blood vessels, it can cause damage to the glomeruli, and then the kidneys will be unable to remove waste and extra flow from the blood. With the extra build-up of fluids and the blood vessels, it can also cause the blood pressure to be raised up even more. CKD can further increase hypertension. The kidneys indirectly help to maintain blood pressure in a healthy range. This is done by maintaining the electrolytes in the body, which influence the amount of fluids in the body. When electrolyte levels are high, the body retains more water, which then increases the volume of the blood, causing higher blood pressure. Diseased kidneys are unable to regulate blood pressure, and as a result, the blood pressure increases. Diabetes. The kidneys filter waste products through small vessels known as capillaries. These capillaries filter the blood flow to small vessels, which allows small molecules to pass through the small holes found in the capillaries. The waste products are broken up, which is then absorbed in the digestive system and excreted into the urine. These products are small enough to be filtered through the kidneys, but larger substances such as proteins and red blood cells are too big to pass through the filter and stain the blood. The high levels of glucose in diabetes reduces the GFR. This over time causes leaking of protein and excretion of albumin in the urine, which damage the kidneys and blood vessels and the capillaries. Waste products continue to build up in the blood. CKD can be prevented by maintaining blood glucose levels in the target range. Having a family history of CKD, hypertension or diabetes increases the risk of developing kidney disease. There are currently two types of CKD known to be inherited. These are polycystic kidney disease, also known as PKD, or Fabry disease. PKD usually occurs in adulthood, but can develop in children and babies. Cysts are found on the kidneys and can spread to other organs. PKD is passed from parent to child and also showing a dominant type of inheritance, whereas only one copy of the abnormal gene is needed to cause this disease, as if one parent has the disease, the baby has a 50% chance of inheriting it. Whereas Fabry disease is inherited at birth from the parents. This can be a life-threatening disorder, which a defective gene in the body cannot produce enough of an enzyme called alpha A. These enzymes are needed to remove fatty substances called GL3. Inadequate production of alpha A causes the build-up of GL3 in the walls, blood vessels, and cells in the body. This can cause damage to the vessels and capillaries. Obesity can cause the body to produce excess visceral fat, which is one of the main driving forces for various imbalances seen in metabolic syndrome. Being obese can cause chorioneuropathy, which means increased proteinuria with expansion and scarring of the glomeruli. And recent studies, one being the Farron and Hart study, found a direct correlation between elevated BMI and CKD. This is due to the elevated serum creatinine levels. Smoking also significantly increases the risk of CKD. Studies show that smoking allows other toxins into the body, which is harmful for the kidneys as they filter these toxins. As a result, it increases the risk of proteinuria. This risk of proteinuria can cause renal failure and heart failure. Proteinuria is also caused by hypertension and diabetic neuropathy. Hypertension is usually a side effect of smoking due to the increased cardiac loads of trying to supply the oxygen around the body. When a cigarette is inhaled, CO2 levels increase and O2 levels decrease. Signs and symptoms of CKD can include fatigue, hypertension, reduced appetite, itching, swelling or edema, fluid and electrolyte imbalances, arrhythmias, pulmonary edema or pneumonia, weight loss, decreased urine output.
Uremia is caused by the accumulation of nitrogenous wastes, which are usually eliminated by the kidneys, and is evaluated by measuring the levels of urea and creatinine in the blood. The term literally means urine in the blood, and if untreated, can lead to weight loss, nausea, vomiting, lethargy, confusion, muscle twitching, convulsions, and even death. Management of uremia includes dialysis, which should be commenced as soon as uremic symptoms develop, and also, whilst waiting for dialysis, a low-protein diet will help control gastrointestinal symptoms and reduce the accumulation of these toxic waste products. Fluid control should also be strict to avoid pulmonary edema. It is also important to avoid unnecessary medications, as the kidneys can no longer excrete this. As Miss Allen is experiencing end-stage renal disease, with signs and symptoms of hypokalemia, edema that has not been responsive to diuretics and fluid restriction, and uremic signs, including nausea, vomiting, weight loss, lethargy, and mental confusion, and her GFR test results fall below 10 millilitres per minute, dialysis is required to compensate for her failed kidneys. This will ensure she can remove waste, maintain electrolyte levels, and will help regulate fluid balance. Dialysis is used as a substitute for the kidney's normal function, as it purifies the blood. Although this is a great approach in the management of chronic kidney disease, and the costs are covered by the Australian healthcare system, it can be quite challenging for patients to live their life normally, and may require work absences, resulting in financial difficulties. As this is an important decision for Miss Allen to make, herself, her family, and any significant others must be educated on all the possible treatments, and ensure that she is involved in the decision-making process, whilst the nurse supports her decision. Types of dialysis include hemodialysis, continuous renal replacement therapies, and peritoneal dialysis. Miss Allen will be receiving hemodialysis in the hospital setting, while she is on the waiting list for a kidney transplantation. Hemodialysis is used to extract toxic nitrogenous wastes from the blood and to remove excess water. In hemodialysis, the unfiltered blood goes from the patient to a machine called a dialyzer, which serves as a semi-permeable membrane, replacing the renal glomeruli and tubules, and toxins are filtered out and removed, whilst the cleansed blood returns to the patient. Hemodialysis involves diffusion, osmosis, and ultrafiltration.
It is important to include heparin and anticoagulants in administration of her medication to prevent blood clots in the dialysis machine.
Vascular access. The rate in which the blood is removed, cleansed, and returned to the vascular system is between 200 and 500 millilitres per minute, and involves multiple types of methods for accessing the patient's vascular system. The two vascular access devices designed for long-term use are arteriovenous fistula, which is commonly referred to as AV fistula or AVF, and arteriovenous graft or AV graft. Although AV fistulas are the preferred method for vascular access, this method requires the patient's vessels to be strong enough for an AV fistula. As Mrs. Allen has diabetes and hypertension, which may have compromised her vascular system, an AV graft may be required as a second option in order to undergo hemodialysis. This graft will be placed in her forearm, although other sites include upper arm or upper thigh. This differs from the AV fistula as it is a looped, biological, semi-biological or synthetic tube that connects an artery to a vein rather than a direct connection of an artery to a vein. An important nursing intervention is to regularly check for the presence of a bruit, which is a swishing sound, or a thrill, which is a vibration, in the graft, which indicates blood flow. Advantages of an AV graft are that it delivers a solution for small or weak veins. It can be used as soon as 2 to 4 weeks after placement, as AV fistulas take longer, and the surgery is usually done on an outpatient basis under local anaesthetic. The disadvantages of an AV graft are that it is a synthetic material in the body. It increases the risk of infection, blood clotting, and aneurysms. Frequent blood clots can block the flow of blood through the graft. The AV graft closes more quickly than the AV fistula. They need constant attention and upkeep by the nurse, and they do not last as long as the AV fistula and will most likely require replacement. Kidney disease is a progressive disease that cannot be cured. The complications will continue to worsen and require more aggressive treatment. There are many complications that may arise whilst Miss Allen undergoes dialysis, including these listed. Additional nursing management includes constantly monitoring Miss Allen, the dialyzer, and the dialysis bath. Support, assess, and educate Miss Allen. Maintenance of the vascular access device. Psychological needs. Education. Promoting nutrition and fluid restriction. Promoting medication adherence. And also the management of her pruritus, restless legs, sleep apnea, and muscle cramps. It is important that the nurse continuously screens Miss Allen for signs and symptoms of depression, and also reduces the causes of depression that are associated with chronic kidney disease, such as her insomnia, and any side effects that may arise from medication therapy. As Mrs. Allen has chosen intermittent hemodialysis in the hospital setting, she must attend hospital 3 times a week for a duration of 3 to 4 hours. Depression is a frequent symptom accompanying chronic kidney disease, and it can affect 1 in 3 people on dialysis. A self-management program significantly decreases depression, improves quality of life, enhances patient satisfaction, and also reduces medical costs in those with chronic kidney disease. It is therefore important that the nurse educates Mrs. Allen and her family on the importance of self-management for chronic kidney disease and provides a reference for the delivery of relevant healthcare, as well as counselling, psychotherapy, or other mental health services if necessary. It is also pivotal that the nurse offers opportunities for Mrs. Allen and her family to express how they are feeling and to discuss end-of-life options. Aspiratus may be caused by calcium and phosphate imbalance, inadequate dialysis, overactive parathyroid gland activity, high levels of magnesium and vitamin A, and nerve changes in the skin. It can be difficult to treat the underlying cause. However, the nurse can alleviate the symptoms by avoiding the use of soaps and detergents and using evening primrose oil, skin moisturizers, and topical capsicum, only if she can tolerate the burning sensation on her skin. If these do not alleviate Mrs. Allen's pruritus, she may be referred to a dermatologist for ultraviolet light B therapy. To Mrs. Allen's restless legs, the nurse may organise home therapies, such as relaxation techniques, massages, warm baths, warm or cool compresses, and exercise, and also to replace iron status if she is deficient. To Mrs. Allen's sleep apnea, the nurse must educate her on the importance of avoiding alcohol, weight reduction, and continuous positive airway pressure therapy, as her obesity may be causing obstructive sleep apnea. Muscle cramps may be caused by imbalances in fluid and electrolytes, peripheral neuropathy, or peripheral vascular disease. To manage Mrs. Allen's muscle cramps, the nurse must promote stretching, massages, and tonic water. The nurse must also educate Ms. Allen on the importance of controlling cardiovascular risk factors, such as treating hypoglycemia associated with her diabetes, treating anemia, cessation of smoking, healthy weight loss, physical activity, and also nutrition.
Managing fluid and electrolyte imbalances. So this includes fluid restriction to prevent weight gain, heart failure, and pulmonary edema, limiting protein, as protein can cause accumulation of nitrogenous wastes, limiting phosphate, limiting potassium with careful monitoring of potassium levels, limiting sodium, and increasing calcium. Implementing a fluid balance chart during the care of Miss Allen is vital, so we must include monitoring her intake orally and intravenously, and monitoring her output, including urine, vomiting, diarrhea, and diaphoresis. Assessing the patient is vital. The nurse must assess and monitor the patient's weight daily, check for edema and jugular vein distension, as these can both indicate fluid overload. Nurse must listen to lung sounds such as crackling, as this indicates pulmonary edema. Check blood glucose levels and maintain this within a healthy range. Check blood pressure, as Miss Allen is hypertensive. Check heart rate and respirations, while focusing on Miss Allen's work of breathing and use of accessory muscles. The DASH diet is a very effective method that should be utilised during the care of Miss Allen. So this includes increase in fruit, vegetables, low-fat dairy products, and reducing in red meat, sugar, saturated fats, and cholesterol. It is important for the nurse to consider the NSQHS standards. This includes Standard 3, Preventing and Controlling Healthcare-Associated Infections, which includes techniques and strategies to prevent Miss Allen from receiving an infection, such as using aseptic techniques, 5 moments of hand hygiene, cleaning, disinfecting, and sterilising equipment and the environment. Standard 4, Medication Safety. When administering medication to Miss Allen, ensuring that the medication is clinically appropriate is vital, and the nurse must consider the 6 rights of administration. Standard 5, Patient Identification and Procedure Matching. The nurse must correctly identify Miss Allen and match her identity with the treatment that is intended.
Aluminium carbonate may be used to reduce hypophosphatemia. It binds with phosphate ions in the intestines to form insoluble, which lowers blood phosphate levels. It comes in a 600 mg tablet, and the recommended dose is 600 to 1200 mg 4 times a day. Side effects include constipation, intestinal obstruction, aluminium intoxication, and electrolyte imbalances.
ARBs work similarly to ACE inhibitors in regards to treating hypertension. However, ARBs have less side effects and don't cause a persistent cough like ACE inhibitors do. Losartan is an antihypertensive drug. It slows the progression of nephropathy with elevated serum creatinine and proteinuria in patients with hypertension and type 2 diabetes. It's metabolized in the liver and excreted in the urine. It comes in 25 mg and 50 mg tablets with a maximum daily dose of 100 mg. Side effects include headaches, dizziness, low blood pressure, abdominal pain, nausea, dry mouth, respiratory tract infections, rash, and dry skin.
Maxilon may be used as a PRN medication. It is an antiemetic drug used to control nausea and vomiting related to diabetic gastroparesis as it slows the GI activity. It comes in forms of tablets and ampules. The recommended dose orally is 10 mg. IM and IV doses range between 10 to 20 mg. Side effects include restlessness, dizziness, insomnia, headache, facial muscle spasms, tardive dyskinesia, and constipation or diarrhea.
Loop diuretics such as bumetanide may be used to treat edema, hypertension, and renal disease. It comes in 1 mg oral tablets with a maximum daily dose of 10 mg. Side effects include fluid and electrolyte imbalances, hypovolemia, dehydration, hypotension, headache, nausea, dizziness, dry mouth, and rash. To avoid nocturia, avoid taking this drug in the afternoon.
While administering these medications, there are important factors to consider. The nurse must check for contraindications and adverse reactions. Consider impairment of renal or hepatic function, monitor fluid and electrolyte levels, assess neurological status, monitor vital signs and compare them with a baseline OBS, consider GI disturbances and offer food if appropriate, establish baseline data from physical examination and continuously monitor. Monitor lab test results, consider rights of medication administration, comfort and safety measures, offer support, encouragement and education regarding medication therapy, and assess the effects of the drug.
These are our references.